Hello everyone, a very warm welcome from the Australian National University here in Canberra. I hope that you and your loved ones are keeping safe and healthy. I'd like to start by acknowledging the Ngunnawal and Ngambri people who are the traditional owners of the land where ANU is located and where we are broadcasting to you today from. And I pay my respects to their elders past and present. Many of you are joining from various parts of Australia, India, and the globe. And I would also like to acknowledge the traditional owners of all those lands and pay my respects to their elders past and present. I am Devashi, a medical student and a volunteer for the ANU COVID-19 peer support program. And joining me are my colleagues, Dr. Deepthi Talaulekar, who is a clinical hematologist and the program lead for the ANU COVID-19 peer support program. And we also have Dr. Pinky Dharmshaktu, who is the Associate Medical Director at Merck Healthcare and also a volunteer with this program. Now, before I introduce our speakers and panelists for today, just a couple of housekeeping notes. All attendees have their video and microphones switched off, and this is just to keep the sound quality clear and reduce any interference during the webinar. I encourage all the attendees to ask questions, and to do so, please use the Q&A button that you can see towards the bottom of your screen. If you do not wish to be identified, you can also submit your questions anonymously. And you can submit your questions at any time. The speakers and the panelists will get to the questions at the end of the talk. A quick note on the polls, there will be some questions that might pop up on your screen during the talk. Please do select your preferred response to those questions. We assure you that all responses will be anonymous. If you have any technical issues or have any questions about the talk, please email international.health@anu.edu.au and we will try to assist you as best as we can. And finally, please note that this forum is being recorded. So today's webinar will be delivered by Dr. Rajiv Pathak and Dr. Charles Itty, where they will review the cardiac complications of COVID-19 and their implications on the management from an Australian and an international perspective. This will then be followed by a panel discussion, which will include cardiovascular experts from India, which I will shortly introduce. And they will also discuss more practical issues and also answer any questions from the audience. So we have Dr. Rajiv Pathak, who is a cardiologist and the clinical director for cardiac electrophysiology and pacing at the Canberra Hospital, the Australian National University, as well as the Canberra Heart Rhythm Centre. And we have Dr. Charles Itty, who is an interventional cardiologist and the Deputy Director of Cardiology from the Canberra Hospital. I'd also like to welcome our esteemed panelists. So we have Dr. S.P. Abhilash, who is the professor in cardiology from Sri Chitra Thirunal Institute for Medical Sciences and Technology from Kerala, India. And he's also the former cardiac electrophysiology and device therapy fellow from the Canberra Hospital. We also have Dr. Rajneesh K. Calton, who is the professor and head of the Department of Cardiology, Christian Medical College and Hospital from Ludhiana, Punjab, India. And we have Dr. Ullas Pandurangi, who is the Chief of Division of Cardiac Electrophysiology and Pacing at Madras Medical Mission and Arrhythmia Heart Failure Academy. It's a great pleasure to have you all here today. So with this, let's begin the webinar itself. I'll hand it over.
Good evening, everyone. Rajiv Pathak here. So I want to thank Deepthi and ANU for this kind invitation. We look forward to having a good discussion, and really most importantly, it's to try and share and really learn from our Indian colleagues. It's my extreme pleasure and honor to introduce Dr. Ullas Pandurangi, a very close friend, an excellent electrophysiologist and one of the thought leaders of electrophysiology in India and worldwide. We have a joint program where we share each other's knowledge, expertise, and understanding of pathophysiology quite frequently. And Dr. Pandurangi agreed to participate as a panelist, and I will look forward to hearing from him his experience of of COVID and arrhythmias, which have, I think they have faced more than us in Australia. So while we'll be presenting, it'll be an opportunity for us to learn from him. The second panelist is Abhilash. He is very close friend. He was our fellow, and he left and went back to India, and he's an associate professor in Sri Chitra in Kerala. His knowledge of electrophysiology is commendable, and he has also been in the hotspot, an area where he has seen lots of patients with COVID. In fact, Kerala, I think, has got lots of cases still ongoing, and we look forward to hearing his thoughts about the COVID, the arrhythmia, and about the cardiac involvement. So I'd like to thank all the three panelists, Dr. Carlton, Dr. Pandurangi, and Abhilash for agreeing to participate in this program. I'll hand over now to Charles to start the presentation.
Is it all good?
Yeah, all good.
All right, great. So I'll start with the part one of this COVID-19 cardiac complications, and Rajiv will focus on the arrhythmia side. As we have discussed before, we are quite keen to have the opinion and the experience of our esteemed Indian panel afterwards. So this is my outline for the presentation today. I'll start briefly just the epidemiology. We'll go through a couple of case studies, pathophysiology of cardiac complications, various cardiac manifestations in COVID-19. And then I'll touch a few areas like troponin elevation, myopericarditis, STEMI management. Another hot topic is RV dysfunction, COVID-19 vaccine, and just a slide about evidence-based therapies. So this is the dashboard which I accessed a couple of days ago from Johns Hopkins University, which is quite well known. As you can see, on 7th of August, there has been more than 4 million deaths across the world. About 4 billion vaccines have been administered, and around 200 million cases has been recorded. And as you can see on the side panel here, India scores quite high up in this list after United States. Now, this is the daily confirmed new cases of COVID-19, again from Johns Hopkins website. As you can see in this slide, the orange line corresponds to India, and the light green line corresponds to the United States. Now, SARS-CoV-2 virus, it's a coronavirus, as we all know. It causes common cold, but there are 3 viruses in this group has caused severe acute respiratory syndromes, which are SARS or SARS-CoV-1, and then MERS, which was and then COVID-19, which is the most recent one, which was first diagnosed in 2019. So the disease spectrum, this is from a study from China, a report of 72,000 cases. 80% of the cases, the disease is mild with no pneumonia or mild pneumonia. In 14% cases, you get a severe disease with dyspnea, reduced oxygen saturation, and critical disease. It is seen in 5% of the cases where people develop respiratory failure, shock, multi-organ failure, and need of ICU and ventilator care. Now, one important finding which has been known from this is that the pre-existing cardiovascular disease increases the risk of death from COVID-19. This is, as you can see in this table here, compared to someone with no comorbidities, the case fatality rate goes from 0.9 to 10.5% if you have pre-existing cardiovascular disease. So with this background, I'll jump into these case studies. This is from JAMA Cardiology 2020, a case from Italy from March 2020, 53-year-old Caucasian woman, severe fatigue for 2 days, had fever, dry cough the week before, no chest pain or dyspnea, no previous history of cardiac illness. Sorry. So on examination, her heart rate was 100 beats per minute. Blood pressure was on low at 90 by 50 millimeters of mercury. Oxygen saturation 98%. Temperature is afebrile. So this was her ECG. On presentation, there is a millimeter ST elevation in inferior leads and less than millimeter ST elevation in lateral chest leads with some ST segment depression at AVR and lead V1. And this was our chest X-ray, which was reasonably unremarkable, I would think. The blood test reports over day 1 to day 7. The main highlights are there is elevation of high sensitivity troponin T, which peaked at 0.89. CKMB elevation, there's elevation of NT-proBNP. The CRP levels were marginally raised. A nasopharyngeal swab showed a positive result for COVID-19. Now let's go to the first poll question here. What is the most likely diagnosis? As you're voting on this poll question, I'll go ahead with my presentation. So there was, the patient had an echocardiogram, which showed a global hypokinesis with an LV ejection fraction of 40% and small pericardial effusion. And she underwent urgent coronary angiography, which showed no obstructive coronary disease. She subsequently had a cardiac MRI, which showed an ejection fraction of 35% global hypokinesis. And T2 mapping showed interstitial edema, and there was diffuse late gadolinium enhancement in both ventricles with small circumferential pericardial effusion. These are the images of cardiac MRI, which shows interstitial edema and enhancement and late gadolinium enhancement. So the diagnosis was, we got a poll results back here. 35% of the audience think is acute ST elevation myocardial infarction, and 43% thought it was acute myocarditis. So in this case, as I've described already, this is a diagnosis of COVID-19 myopericarditis. The patient received dobutamine support for 4 days, heart failure therapy. Some of these medications mentioned here, this was based on whatever the treatment during March 2020, and like hydroxychloroquine, this combination of antiviral agents, they are not recommended at the current, with the current knowledge evidence, due to lack of evidence. And she had methylprednisolone, and patient made a steady recovery with improvement in LV function. So I'll go to case report number 2. There is a 45-year-old man, no previous medical history, central chest pain for 2 hours, a 2-week history of COVID-19. ECG shows anterior ST segment elevation. I don't have the ECG with this presentation. It was published in JACC as a case report. Again, we'll go directly to the poll question again. As we are answering this question, I'll go ahead with my presentation. So this patient had a coronary angiography. And as you can see here, there was distal occlusion of LAD, this arrowhead here. There's fresh thrombus in mid LAD, and the normal looking circumflex in RCA. He also had a cardiac MRI, which showed the edema in the septum. There was late gadolinium enhancement, including patchy subepicardial enhancement. Now, the management in the cath lab here had a thrombus aspiration. I have a Paul Russell back here. 61% of the audience thought it was acute ST elevation myocardial infarction, 17% acute myocarditis. So this patient had a 2B3 inhibitor, tyrosine. He also had optical coherence tomography, or OCT, which showed no plaque rupture or evidence of atherosclerosis. So the diagnosis was acute myocardial infarction secondary to epicardial thrombotic occlusion associated with COVID-19. And there was also a possibility of microvascular thrombosis based on the cardiac MRI finding. And the patient was discharged on clopidogrel and rivaroxaban, oral anticoagulant. So let's jump to the pathophysiology briefly. SARS-CoV of COVID-19 virus binds to an ACE2 receptor, angiotensin converting enzyme 2 receptor on the host cell to gain entry into the cells and for replication. And ACE2 receptors are expressed in type 2 pneumocytes in the lungs, cardiomyocytes, pericytes, and endothelium, mainly in the vascular system. And as we already know, ACE2 is a key member of the renin-angiotensin system. Now, ACE2 is expressed throughout human body, but they are abundant in the lungs, especially in the epithelial cells and type 2 alveolar cells, which explains why these patients develop ARDS and respiratory failure. They're also in cardiomyocytes, causing the cardiac complications, and in the vasculature, leading to endothelial dysfunction, vascular inflammation, micro or macrovascular thrombosis, and vasospasm. Now, this slide explains, this is a busy slide. I'll just take a minute to explain this. Cardiovascular involvement in COVID-19, the proposed mechanisms. So the infection of endothelial cells and pericytes can lead to microvascular and macrovascular dysfunction, leading to thrombosis as a mechanism for acute coronary syndrome, as we saw in case number 2. There is immune overreactivity and a cytokine storm, and which can potentially lead to plaque instability and acute coronary syndrome. It can lead to myocarditis, stress cardiomyopathy, and all these can lead to heart failure. Also, immune-mediated or direct myocardial cell damage can lead to presentation with myocarditis and subsequently leading to cardiac arrhythmias. And another mechanism is the cardiac stress from hypoxemia and pulmonary embolism, leading to a type 2 myocardial infarction, including right ventricular dysfunction. Now, if you look at the COVID-19 timeline, there's an exposure period up to day 5, and there's a pulmonary phase, which is up to day 10. There's a hyperinflammatory response phase, and then the recovery phase. And cardiovascular effects can start concurrently with the pulmonary phase and can extend even further. This is a timeline adopted from a different publication. As you can see, there's an acute phase, there's a convalescent phase, and a chronic phase, which would go to several years. And this proposition is based on previous SARS epidemic. And we all know that there's this entity called long COVID with ongoing cardiopulmonary and neurological symptoms, predominantly chronic fatigue, dyspnea, chest pain, dysautonomia, and especially lots of patients with postural orthostatic syndrome. According to one study, there were 60 to 80% of discharged patients reported at least one symptom 50 days after the COVID diagnosis. Now, the various cardiac manifestations in COVID-19, it varies from an asymptomatic troponin elevation and or ECG changes, and it can extend to myocarditis, stress cardiomyopathy, heart failure, acute coronary syndrome, cardiac arrhythmias. They can get inflammatory or cardiogenic shock with type 2 myocardial infarction, right ventricular dysfunction secondary to ARDS, hypoxemia, and pulmonary embolism, venous thromboembolism, and more recently, there could be a Kawasaki type syndrome in children and similar inflammatory syndrome in the adults. Coming to troponin elevation, it's quite common to have troponin elevation in these patients, and it has been shown that an elevated troponin is a strong predictor of in-hospital death, even in those without any known cardiovascular risk factors, according to this publication. And this is a meta-analysis which looked at patients with elevated troponin I levels. They had approximately 8 times higher odds of poor outcomes compared to those who didn't. This is a meta-analysis published in 2020. Now coming to COVID-19 myopericarditis, the evidence of myocardial injury is common with elevation of troponin, as we just saw. However, the incidence of clinical myocarditis is not clearly known. Among the 68 fatal cases from Wuhan city in China, 7% of the deaths were attributed to myocardial damage with circulatory failure. And in 33% cases, myocarditis may have played a role in the death. So there is no clear data at present to say the incidence of myocarditis. And about 10% of patients with myocarditis have pericardial effusion. Relation with lung involvement is not very strong. As we saw in our case number 1, there was not many pulmonary manifestation in the patient who presented with myocarditis. Pericardial fluid is typically sterile, and patients with previous cardiac disease are at increased risk. Now, this article was published in Heart Rhythm about, it gives a suggested management protocol for myocarditis. So there are some differential diagnoses being discussed here, but coming to the management side, the recommendation is to avoid treatment for sinus tachycardia with negatively inotropic agents, as the cardiac output may be dependent on a tachycardia, such as metoprolol, diltiazem, verapamil. As we all know, non-steroidal agents should be avoided. Patients who go into heart failure or cardiogenic shock, the treatment is according to the standard protocol for heart failure and cardiogenic shock. And some of these patients will require mechanical circulatory support with ECMO or ventricular assist device or balloon pumps. And there are specific therapy such as tocilizumab, which is an antagonist of IL-6, which we will discuss a little bit later, and different cardiac arrhythmias. Rajiv will cover that. And we should also be cognizant about QT prolongation, because some of the drugs being used, like antimalarials and macrolides, are known to cause QT prolongation. Now, let's jump into the STEMI management in COVID-19 pandemic, which is a hot topic. This paper, which was published in New England Journal of Medicine, looked at 18 patients who came with ST elevation during the first month of COVID outbreak in the New York City. Out of the 18 patients, 9 of them underwent coronary angiography. They had a protocol if the patient had a normal ejection fraction and no regional wall motion abnormality. They didn't take these patients to cath lab. which I thought was a reasonable approach. Now, 6 out of 9 patients who had coronary angiography, 67% had obstructive coronary disease, and the rest had no obstructive coronary disease. 13 patients died in the hospital, 4 patients with myocardial infarction, and 9 with non-coronary myocardial injury, which indicate that the myocarditis, those who presented with myocarditis were more acutely ill and they had a worse outcome compared to those presented with obstructive coronary disease. Now, the management of patients with ST elevation in the COVID-19 pandemic, some authorities in last year have proposed thrombolysis as a faster and safer method of reperfusion, but there are several issues with this proposal. As we just saw now, several patients, 30 to 39% of patients with ST elevation has no obstructive, and they have a non-coronary etiology. And these patients also have a higher incidence of hemorrhagic stroke, up to 9% in one study. So it's probably not ideal or wise to thrombolyze these patients as a blanket rule. The ACC, SCI, and American College of Emergency Physicians released this statement, which says primary coronary angioplasty should remain the standard of care for STEMI patients at a PCI-capable hospital when it can be provided in a timely fashion, with an expert team outfitted with the PPE in a dedicated cath lab. And a fibrinolysis-based strategy may be entertained in a non-PCI-capable referral hospital, or a specific situation where a primary PCI cannot be executed or is not deemed the best option. This was recommendation from ESC, which also is quite similar to the American guidelines. The primary PCI remains the reperfusion therapy of choice if feasible within 120 minutes, performed in a safe manner for healthcare providers and other patients. The Cardiological Society of India had come up with this guideline, which was published in Indian Heart Journal in 2020, March-April edition. Again, primary PCI is recommended in PCI-enabled centers, thrombolysis in isolated facilities. And they also mentioned that we should assess the risk-benefit ratio of reperfusion against the risk of nosocomial infection. The New South Wales government has released this paper for the recommendation for Australia, state of New South Wales. During COVID-19 pandemic, primary PCI should be offered as the first line of therapy for patients presenting with ST elevation MI. Now, in centers where there are less available staff or other resources to safely perform a primary PCI, including a lack of PPE, fibrinolysis may be appropriate, if not contraindicated. In a busy primary PCI unit, if there are simultaneous presentations, some patients may need to be thrombolyzed. And also, we should keep in mind that if patient had high exposure risk, they will need additional precautions. I'll just quickly go through a couple more topics and I'll finish. Right ventricular dysfunction has been shown to be an important prognostic marker, and adverse remodeling of right ventricle with dilatation or dysfunction was associated with more than twofold increase in the risk of death, even after controlling for age and biomarker elevation. Just a slide about COVID-19 mRNA vaccine and myocarditis. As you can see in this graph, the incident cases of myocarditis until November 2020, and there was an increase noticed in the incidence of myocarditis. The crude incidence of myocarditis in males aged 12 to 29 years was 40.6 cases per million after second dose. It was considerably less in females. However, in places with high risk of COVID-19 transmission, the risk-benefit ratio still favors use of mRNA vaccines. And with AstraZeneca vaccine or Covishield, we know that there is a risk of thrombosis with thrombocytopenia syndrome, with the incidence of 4 per million in UK, and it's been reported as higher in Europe and Australia. The risk of TTS below 60 years is 27 to 31 per million in Australia and becomes less in older population. Just a slide about the evidence-based therapies. There's a profusion of studies and clinical trials being underway about the treatment options. Remdesivir has been shown to be beneficial as an antiviral agent. There are anti-inflammatory therapies like baricitinib, which is a Janus kinase inhibitor, and tocilizumab, which is an anti-IL-6 monoclonal antibody. To summarize, those with pre-existing cardiovascular disease are at increased risk of death from COVID-19. Handheld echocardiogram is a valuable initial tool in the assessment of those with elevated troponin and or an ECG abnormality, as we will see many of them, because troponin elevation is quite common with patients presenting to the hospital. Cardiac manifestations could vary from asymptomatic troponin elevation to fulminant myocarditis, acute coronary syndrome, and arrhythmias. Troponin elevation is a strong predictor of mortality and morbidity. We should consider COVID-19 myocarditis in those presenting with ST segment elevation on ECG. PCI remains the standard of care for STEMI patients at a PCI-capable hospital when it can be provided in a timely and safe fashion. Fibrinolysis could become the best available option for some patients under special circumstances. Right ventricular dysfunction is a marker of increased risk of death. There is some increased reports of myocarditis after mRNA vaccines in younger males. Benefits would still outweigh risk if the risk of exposure is high. However, careful risk-benefit assessment is needed in this age group if the risk of exposure is low. That finished my presentation. I'll hand over to Rajiv to continue with the discussion on cardiac arrhythmias. Thanks, Rajiv.
Thanks, Charles. I think I'll have to share because otherwise I won't be able to advance my slides. So can you unshare your screen and I'll share my screen? Because otherwise Absolutely. You'll have to advance my screen. Huh?
Yeah.
So let me share my screen now. That's wonderful. Guys, everyone can see me. Thank you very much, Charles, for excellent presentation. I think you have set a really good scene for what happens with COVID, and you've covered the myocardial infarction, the coronary artery disease, and also the myocarditis and heart failure we see. You touched upon cardiac arrhythmias, and I'll try and take things further from here. So I'm going to talk about cardiac arrhythmias, which are seen in patients with COVID-19. The biggest disclosure we all have is that we haven't seen that many number of COVID-19 patients in Australia. However, the basic problems remains similar, and I'm going to try and discuss a couple of them, and then we will invite our esteemed panel members to then discuss about these. So I looked at the website to see what is the incidence of arrhythmias we see in patients with COVID-19, and this is worldwide case survey, which is actually on live, and it continues to change, and it shows that atrial arrhythmias are quite common in patients with COVID-19 infection. In fact, 7 out of 10 can have atrial arrhythmia, and roughly 20% of patients can have life-threatening ventricular arrhythmias. So this is the study data from a COVID study, which is from the Copenhagen group of the population where they looked in America, of patients who have arrhythmia, and they found about roughly 20% of the patients can have major arrhythmias. And they're looking at the numbers. Supraventricular arrhythmia seems to be the commonest. Atrial flutters, sinus arrhythmias, having AV blocks and ventricular arrhythmias remain minor segment of the patients who are having these major arrhythmias. When we look at the non-major arrhythmias, we see patients have premature ventricular contractions, premature atrial contraction, they can have sinus tachycardia or inappropriate sinus tachycardia. And we will be going into postural orthostatic tachycardia as we go on in the presentation. And sometimes patients just have a sinus tachycardia or abnormally increased heart rate in these patients. When we look at the mechanism which may be responsible for these arrhythmia, as Charles was talking about, they can be direct effect or could be an indirect effect of the infection or systemic illness itself. The direct effect can be because of the direct cardiotoxicity of the virus itself on the myocardium, or because of the dysregulation of the renin-angiotensin system. Charles was talking about the endothelial damage, which could lead to either macrovascular or microvascular injury and Kawasaki type of inflammation or myocardial infarction, which he elegantly showed with few studies. It could be because of the immune dysregulation and the autoimmune mediated attack on the ganglion itself or the myocardium, which leads to then arrhythmia and dysregulation as we see. Or finally, it could be a demand-supply mismatch, either because of the acute systemic inflammation or because of the acute stress in the body leading to further scarring. All of these different mechanisms, which could be the pathophysiological mechanism behind what we see, we finally see an acute cardiac injury, myocardial infarction, myocarditis, which Charles was discussing about. And eventually, unfortunately, when you have a myocardial injury, you can then have cardiac arrhythmias, you then have heart failure, and associated problems, shock, and shock itself can lead to demand-supply mismatch, further extending the cardiac injury and myocardial infarction or arrhythmias. Similarly, you can have pulmonary embolism, which could increase the right ventricular failure, or increase demand, and finally leading to this demand-supply mismatch, leading to further compromise and arrhythmias. When more specifically, when we look at the arrhythmia itself, as I was talking about, multiple different arrhythmia from the supraventricular region like SVT, atrial flutter, and atrial fibrillation. From the node region, you can see a heart block, or you can have ventricular arrhythmias such as PVCs, or ended up having sustained monomorphic ventricular tachycardia or polymorphic VT. The potential mechanism which is proposed in this JACC paper, as we all can appreciate, could be because of hypoxia, either because of the heart failure or pulmonary embolism. Myocarditis, which could be either because of the direct injury or the systemic inflammation, abnormal host immune response, myocardial ischemia, the strain, or the electrolyte arrangements which we see, either because of the systemic failure leading to renal impairment, finally leading to that, or because of the overall systemic illness itself, intravascular fluid imbalance, or finally because of the drug side effects, because of the multiple medications these patients could be on, or if they are on drugs such as hydroxychloroquine, along with medications such as azathioprine or one of the antivirals, and they can then finally lead to potentially life-threatening QT prolongation and lead to arrhythmias and death. The management strategies, of course, remain threefold. The most important is general management, which will be for any non-COVID critically ill patient. Hemodynamic support to these patients, respiratory support, intensive care support remain the primary, the framework based on which the treatment should be given. Along with that, the specialized treatment should be based on, number one, what arrhythmias we are dealing with. Are we dealing with supraventricular arrhythmias? Are we dealing with heart block or ventricular arrhythmia? If you are dealing with heart block, as we were discussing, a temporary pacemaker can bridge the patient through the acute stage, and finally, once they recover, the decision can be made whether these patients are going to need a permanent pacemaker or not. Management of QT prolongation in these patients can be something very tricky, either because of the drugs they are on, or because of the direct effect of the virus itself leading to QT prolongation. So moving from there, one of the commonest cardiac arrhythmias seen in patients with COVID-19 is dysautonomia. Now, most patients will experience palpitations, and that's not considered as postural orthostatic tachycardia syndrome. That will be just either inappropriate sinus tachycardia or generalized sinus tachycardia. But what can happen that these patients either acutely or in chronic settings end up becoming patients with autonomic dysfunction, and the condition what we generally know as postural orthostatic tachycardia syndrome. The syndrome is defined as condition when there is more than 30 beats per minute increase in the heart rate by just change in the posture on a tilt table test, or if you have an increase in the heart rate without a drop in the blood pressure or associated hypotension, those patients we consider as postural orthostatic tachycardia syndrome. There are various proposed mechanisms which could be responsible for this. Now, in an acute setting, it could be just primarily the direct effect of the virus itself. The viral infection leads to hyperresponsiveness of the immune system, which then lead to autoimmune inflammation, immune suppression, and leading to various other autoimmune reactions, finally leading to acute POTS. Now, this could be because of the direct autoimmune antibody-mediated damage to the autonomic ganglions itself, leading to ganglionopathy. It is not surprising that nearly 50% of these patients normally have acetylcholine receptor antibodies. And there is proposed role of immunotherapy in this subset of patients. So that's mostly acute. In chronic setting, this chronic POTS could be either primarily because of the hypovolemia itself, or could be because of the direct damage to the medullary central function, which leads to uninhibited sympathetic overdrive, leading to palpitation, or could be because of cardiovascular deconditioning. Now, these patients who are sick, they decondition. Their myocardial, the mass reduces, the intravascular volume reduces, their stroke volume reduces. All of these can finally lead to chronic POTS in these patients. Similarly, there's autoimmune reaction, which finally leads to this autoimmunity and causing the chronic POTS. As in any other patients, the chronic POTS, these patients should be treated initially with conservative management such as hydration, compression stockings. There are medications which can be given, although I must admit, these are some of the most challenging patients we see. Medications such as beta blockers, most commonly propranolol, such medications ivabradine, which can modify the sinus node function. There are medications such as midodrine, which can be given to increase the blood pressure. And there are various other battery of medications and immunotherapy can be given in these patients. Also, cognitive behavioral therapies has been utilized. I'm an electrophysiologist, and that to invasive electrophysiologist, we will always discuss about catheter ablation, but I must admit that catheter ablation has minimum role. However, if a patient end up having a chronic inappropriate sinus tachycardia, extremely rare circumstance, you can use catheter ablation for modification of sinus node. Almost something which I have once seen work that well. I'll discuss that with my panelists at a later stage to see if they have experience and if they can tell us if that has been helpful for for them. I'll switch my gear from here and we'll talk about COVID-19, and especially in patients with inherited arrhythmias. Now, there are 4 different inherited arrhythmias we will talk about, and that seems to be a major issue because some of the drugs which we use in these patients can have significant effect on the QT prolongation itself. And what if they have a inheritable or congenital long QT to start with? Now, there are multiple medications which has been used in different sub-studies in patients with long QT, in patients with COVID-19. We all know the drugs such as hydroxychloroquine and chloroquine. Now, these drugs are metabolized by cytochrome P450 mechanism. And there are additional antiviral drugs or macrolides which can be used in the similar setting. And we need to be mindful that most of these drugs can have cross reaction and have similar metabolism through the liver cytochrome P450 genes. And that can lead to a dramatic prolongation of QTC and can lead to life-threatening arrhythmias. The drugs such as ritonavir or leponavir can be used. Macrolides such as azithromycin, which also is a potent inhibitor of cytochrome P450 and leads to a dangerous increase in some of these drug levels and finally leads to arrhythmia. So if we have a patient who has long QT, mostly fever itself is not responsible for long QT 1 or 3. However, long QT 2 patients can have fever-triggered arrhythmias, and in those patients, you have to be very careful, and these patients need to be monitored. Now, when you start medications in these patients, you have to monitor their QT interval, especially if they're going on hydroxychloroquine or if you're adding antiviral agents, both in patients with congenital or acquired long QT. And these patients, of course, we need to slowly and monitor their long QT every 4 hours to see if there is a QT prolongation. Once the QT interval is more than 500 milliseconds, the general advice is to then try and have a closer follow-up, may have to consider intensive monitoring, make sure that the potassium is above 4 in those patients, and may have to even consider discontinuing some of these medications. Patients with acquired long QT, or if they have a combination of multiple drugs, it is advisable that these patients, the potassium levels should be high and should be around 5 to reduce them having life-threatening arrhythmia. The second inherited arrhythmia, which can be commonly seen, is Brugada syndrome. Now, patients with Brugada syndrome, one of the highest risk of arrhythmia in these patients are fever-mediated. So the most important treatment should be give them paracetamol to try and get rid of the fever. By getting rid of fever, we will be able to reduce their risk of going into cardiac arrhythmias anyway. Unfortunately, patients with type 1 Brugada, if they have COVID-19 and they start having high fever, they are at a significant risk of having dangerous arrhythmia. And if the temperature goes above 38.5, they can be at extreme high risk. These patients need to be intensively monitored, and they may have to present to emergency department in that settings. Patients who are not part of high-risk groups, such as they are not young people or elderly, drug-induced type 1 Brugada pattern, no symptoms of syncope or no signs of spontaneous type 1 Brugada, they don't have to go to hospital. They should ideally stay at home, because the risk of having cross-infection and causing further, comorbidities and problems are far greater than the risk they have of arrhythmia. ECG abnormalities and arrhythmias, as well as the efforts to reduce the body temperature, as we discussed, is extremely important, that we need to try and get their temperature low so that we can prevent them having these arrhythmia. The third condition we talk about is short QT syndrome. It's again one of the conditions in which you have a short QT, and they are patients with significantly greater risk of having arrhythmia. This is generally a heterogeneous disease. The pathogenic variants at least there are 3 different types, with a potassium channel and chloride bicarbonate exchange genes which are involved. Now, these patients, there is no specific trigger for arrhythmia. So these are not like Brugada or long QT patient, and fever generally is not shown to be one of the higher risks of inducing arrhythmias in these patients. Patients with short QTs are therefore can be monitored at home and rather than trying to go into the hospital setting. Potential drugs for patients with COVID-19, such as chloroquine, may actually be beneficial in patients with short QT, because as we know, chloroquine and hydroxychloroquine increases QTC interval. So medications which if given for COVID-19 and patient had short QT, the risk of having dangerous arrhythmia in those patients are actually less, because of slight prolongation of QTC you see with the drugs. I'll then go to one of the other rare condition, what we call as CPVT, or cholinergic ventricular tachycardia. This is a familial arrhythmia syndrome which is characterized by adrenergic-related ventricular arrhythmia. Now, we have these COVID-19 patients with sepsis. So they have sympathetic drive. Because of the sympathetic drive, these patients are at a very high risk of having both atrial and ventricular arrhythmia. And if they have CPVT, then the risk of having significant ventricular arrhythmia increases considerably in this patient. As always with CPVT, the first line of treatment should always be a beta blocker therapy. In sufficient responsive cases, you can try and use flecainide medication or consider doing left sympathetic denervation. These patients mostly will have VT and VX storms, and sometimes it can be extremely difficult to manage. And as we can imagine, if they have COVID-19 and they have spikes of fever and sepsis going on and in intense inflammatory response, some of these arrhythmias can be very challenging to manage. In these patients, you can try and increase heart rate by temporary pacing, and that can help to try and prevent them going into dangerous arrhythmia. And in the meantime, trying to reduce fever and trying to get rid of sepsis will be the most important thing to do. Whether the stressful circumstances that patients with COVID-19 find themselves, which leads to them having this arrhythmia, or the sepsis itself, seems to be difficult to know, because of course, when the patients have COVID-19, they are extremely stressed. Emotional stress itself and the scare factor could be responsible for the intense emotional response and leading to sustained life-threatening arrhythmias in these patients. Now, antiviral therapy proposed for COVID-19 is not expected to lead to increased risk of arrhythmia in patients with the CPVT. The only potential deleterious pharmacological interaction could be that if these patients are on alpha and beta adenoreceptor mimetic activities. Now, those patients, like patients, if they are have severe sepsis, they might be put on noradrenaline to try and improve their blood pressure. And if these patients have CPVT, they are at extremely high risk for having dangerous ventricular arrhythmia, and it can be very challenging to manage those. As I was discussing, if they are on adrenaline infusion, if they are on dobutamine infusion, or if they are on isopril trying to increase the heart rate, these could lead to life-threatening arrhythmia, and these drugs should be avoided. The other drug which is used as inotrope is Milidon, which decreases the, increases the cyclic AMP basically and works, unfortunately, again, something which should be used with caution. Now, this becomes really tricky. If you have a patient who needs to be on dobutamine, and that's causing ventricular arrhythmia, if you put them on a beta blocker, you are trying to jiggle with these different receptors. And it can become extremely challenging in those patients to see how we are going to manage their arrhythmia. And I'll be asking my Indian colleagues what their experience have been with regards to using these different inotropes, and in setting with the gain to ventricular arrhythmia, what have they been doing to try and salvage those patients. In patients with CPVT, and particularly those who are symptomatic before diagnosis, they should ideally stay on a beta blocker therapy, and we can add flecainide in those patients if it is hemodynamically possible. And on the basis of above, generally the advice has been to try and avoid using adrenaline infusion because of the risk of having life-threatening ventricular tachycardia and ventricular fibrillation in these patients. So I'd like to conclude here, ladies and gentlemen. Cardiac arrhythmias are likely the consequence of the systemic illness, the direct or the indirect effect of the COVID infection itself, either because of the direct myocardial injury, the macrovascular, the microvascular, the autoimmune effect itself. The autonomic dysregulation is not uncommon. It could either be a simple sinus tachycardia, inappropriate sinus tachycardia, and in a worst situation, not uncommonly, they can have acute or chronic postural orthostatic tachycardia syndrome. Patients with inherited arrhythmia syndrome could potentially put a significant challenge in management because of the direct effect or proarrhythmic effect of the virus itself, the autonomic effect it has on the ganglion, or unfortunately, some of the drugs which are used for treatment itself can be proarrhythmic. Patient with COVID-19 can have abnormal PR interval behavior. And they can have either paradoxical prolongation or lack of shortening with increasing heart rate. And that could lead to either a temporary heart block, a sinus node dysfunction, a significant bradycardia, and may require temporary pacing sometimes. So I'd like to conclude here. Thank you very much. And we will now invite our panelists and we'll start the discussion session. So Charles, I will stop sharing my screen we will start the discussion. I'll start the discussion with asking Dr. Ulas, because I'm really itching to really ask his opinion of how and what his experience has been on cardiac arrhythmia in these patients. Dr. Ulas, could you kindly tell us how things have been?
Raju, first of all, thank you so very, very much. And I'm damn impressed. And when I was not with you. Hello, everyone. It is such a privilege. Raju gave me this platform to join with you people. I said I'm impressed with Raju. I also told that I'm always impressed with him in the past. Every time I bump into him, and we are always in constant touch. You know, a few of my registrars are also going to be joining him. Few of them already got trained with him. I'm saying impressed is because Rajiv, you are in a country which is literally, kind of protected, by its own system, or COVID is afraid of invading you. But with all that protective mechanisms in place, you people are gearing up in case if at all it hits you, the way you people have organized this, the way you would like to understand the pathophysiology and how it should be managed. I think it's a great exercise, and I wish all that is what you have learned today does not really come to use later. I hope COVID doesn't affect you people. To give a background about our country's COVID malady here, I think you people are aware that in the latter part of 2019, when this COVID infection was declared a pandemic, there was one particular nation which thought this would never invade us, and that was India. Because we started believing that the kind of environment we live in, not necessarily the so-called geography or the temperature or the humidity, no, even our lifestyle, even the so-called natural immunity what we develop because we are not as much hygienic as what we are supposedly to be. We all believed that we live in such difficult circumstances and our hygiene is so very low. Why COVID would like to affect us? That was the confidence we had till I think February, March 2020. That is when we started recording the cases. And before that, we thought, we are anyway so much affected with the influenza viruses, corona brothers, sisters, and a lot of other viruses. And, we would have taken chloroquine because, 1 in 5 anyway would have had malaria infection. Some natural immunity we thought we have got. But then today, it appears like COVID actually liked us more than anybody. And we were the most susceptible people because we recorded, almost the maximum cases, I think, across the globe, because our health system really does not put a tab on what actually is happening in the healthcare, as you are aware. We do not really boast of the best of the health systems, that is available. So maybe we are recording actually the less number of cases, we are recording the less number of mortality, etc. But still, whatever the records we have, I think you'll be kind of shocked if you are not read it before. As of now, 35 million cases we have recorded. Those are the COVID affected. 35 million cases, which could be, maybe an underestimate. But that's the official record. And for our colleagues and the attendees here, they should know that we have registered 500,000 deaths who could be directly the mortality being directly because of the COVID or indirectly, right? But then that is the statistics, and then we call that, this is the waning phase of a second wave here, and still we are recording about 50,000 daily cases. Can you believe this? 50,000 daily cases. And if you ask me what could be on a particular day, how many people are actually having an active case, if you ask me, it is about 100 to 150,000 active COVID cases across the country. I think this should be enough as far as the enormity of the COVID infection in our country is concerned, right? Now, I think Rajiv, you must be also aware that we have brought in certain documents, Indian Heart Rhythm Society, the arrhythmia group, Indian Heart Rhythm Society. Apart from Charles, whatever he quoted about the STEMI, we also have brought in 3 documents directly pertaining to the COVID arrhythmia issues. To begin with, when we started looking at the utility of the chloroquine and azithromycin and the combination of the drug, and then we started looking at the long QT. Really, it caused, I think, a lot of problem, but it so happened that in our country, the so-called supreme authorities of the medical care, who regulate the medical care, so-called Indian Council of Medical Research and our Director General of Health Services of India, they themselves have realized that in the last 6 months, the use of chloroquine, the use of azithromycin, both as a prophylaxis or for a therapy, and most importantly, remdesivir, I think they have been totally taken out from the treatment regimen. I think that's a big thing. All that arrhythmia, what we were talking about, maybe that could have been aggravated by these therapies. I think so, but we do not have the data, right? So now, when it comes to the present situation, Raju, you must also be aware that our center here is an exclusive cardiac referral center. So what happens here, for example, for the last 2 years, we have seen cardiac arrhythmias, myocarditis, heart failure cases in our center who were most likely incidentally detected to have corona infection. If those patients who have actually had direct corona infection and then direct corona related issues, I think they should have had pulmonary involvement as a major issue. On top of that, the cardiac issues. I think so. But what happens, I have a limited experience of non-pulmonary involvement and corona positive cardiac cases. To be very honest with you, there was only a fear among us here whether this patient, when he comes inside, whether he is going to be spreading the infection to the health workers or to the relatives or to the environment. We have had corona positive, very less lung involvement, cardiac problems. I am not very sure whether they really had a corona infection and that was the result, or they incidentally had the COVID positivity and less of lung infection. It is such a sad thing that whether that particular patient has had the corona related the problem or no, it was the fear or it is the mechanism, the way we treated them actually did not help the patient. Patient comes here, say for example, a complete heart block. The first thing we would do is corona testing, even today. And you see there is so much of the infectiousness of this particular organism. 1 in 10, according to the data, 1 in 10, maybe 1 in 20, they could be corona positive, even if they are asymptomatic, if you really do the kind of a testing. So I'm in a center where we treated less of a pulmonary involvement, only cardiac problem, and then a screening test was done, RT-PCR done, and they became corona positive. So what happened then was a less sicker patient whom we would have treated aggressively even in the past, he was not treated. Only very sick patient with a limited resource and in a very limited way, we sorted the issue out. So corona, when it had not affected the lungs, and if the corona had shown some cardiac manifestations, maybe just an incidental positivity, these patients, I can tell you, they did not get the best of the therapy just because they were corona positive. So what I'm trying to tell you here is, I'm in a center where those patients with heart diseases, and if they were corona just positive and less of a lung involvement, I think we did not treat them properly. We would like to bring out, yeah, so I will end here and then.
That's really, really interesting, Ullas. So as you say that lung and cardiac involvement together leads to arrhythmias, and arrhythmia might have been there and COVID might be just an incidental something which was associated. Abhilash, I understand in Kerala, there is a massive surge of cases as well. What has your experience been regarding the arrhythmia in these subset? And then we go to Dr. Carlton to ask his opinion as well. Huh?
Yeah, good evening, and very happy to hear two excellent talks, and very privileged to be invited for this forum by INU. Yes, actually, Australia is doing some 300 numbers, and Kerala currently does around 20,000 per day, 20 to 20,000 per day. Initially, 300 number used to shock us. Then thousands used to shock us. Now no number shocks us. So that's the situation. But even having said that, we don't like some 50% of the Kerala population got first vaccination and around 20% got 2 doses. It's only 20%, but still we don't see the hospitals full now, and ICUs are not overflooded. There are cases, sick patients, we averages around 100 deaths per day. And still the majority are lung related only. We do see sudden cardiac deaths, but that is just like Dr. Charles told, myocarditis, acute STEMI. Actually, some of the sudden cardiac deaths were actually pulmonary embolisms. So the thrombotic complications are much more than the arrhythmic complications which we enumerated. Of course, we may have some SVTs, atrial fibrillations, but these patients are being treated in COVID specialized hospitals. So they may not be documenting some of the complex ones like CPVT or those things. So we hardly come across those arrhythmias, CPVT or any other ventricular arrhythmias. This is done primarily in COVID dedicated hospitals, critically ill patients.
Sri Chitra is not a COVID.
We are not a COVID specialist hospital, okay. But we do come across COVID patients because the patients come with an arrhythmia or acute MA as enumerated and turns out to be COVID positive.
Dr. Carlton, you are in CMC Ludhiana, is that correct?
Yes.
Could you kindly share your experience with regards to cardiac involvement and what challenges and what arrhythmias you've been, and other myocardial disease you've been seeing here?
Yeah, Dr. Carlton, so I was thinking if you could discuss, I mean, I think Ludhiana has a lot of cases as I can read about it, and you're managing a busy unit there with patients coming to emergency, CCU and cath lab. It'd be great to hear your experience.
Thanks, Charles. It's really nice to see you, the director of cath lab there at Canberra. And I'm thankful to the Australian National University for giving me an opportunity to participate in today's webinar. We have had very excellent talks by Dr. Rajiv and by yourself, and a lot of prospect from the Indian point of view is given by Dr. Ullas and Dr. Sridhar. We are in I'm in a medical college in North India, and we cater to all type of patients. All specialties are there, and a cardiology being dedicated tertiary care center is there. So as mentioned by you, Charles, in the document given by Cardiological Society of India, it's pretty much the same as that in the West, and most of the guidelines have been indicating that if you have an ACS, primary coronary intervention remains the main line of treatment. If you're not able to do that in the stipulated time, then to do thrombolysis, at least to give some form of reperfusion. But we have been actually facing quite a bit of challenge, especially when there is a surge of cases in the city. And especially towards the first wave, in fact, as the lockdown has started, the patients were just not able to come to the hospital. We had a real drop in the number of patients, and there was a delay in the patients to come to the hospital to offer them any form of cardiac therapy and to triage with that. And this was because there was no transport available. There were no medical clinics open. There were very few ambulances. And the patients were very scared to come to the hospital, thinking that they may contact COVID there. And there was also a fear that if they come to the hospital, they may get admitted, they may get